Recording in progress.
Okay. Good afternoon, everyone, and those who are from Korea, my friends, good evening for them. It's a webinar which we combinedly doing with Diabetes Korea. Diabetes India is an association of Indian doctors which has been established by Dr. Shaukat Sadikot, who was past president of International Diabetic Federation. We have our annual meeting of Diabetes India, which is World Congress of Diabetes and Obesity, which we are going to have at Hyderabad International Convention Center, 2026 from 13th Feb to 15th of Feb, and pre-conference symposia on 12th Feb. This 4 days meeting which we are going to have will have around 3,500 plus doctors. Dr. Briz Makkar is organizing chairman and a very senior person from India, and Dr. Manoj Chawla, who is currently organizing secretary for this meeting, a senior diabetologist who is based at Mumbai. Dr. Makkar is based at Delhi. This meeting, which we are doing with Korean Diabetic Society, first we are very much thankful to them that they accepted our invitation. I was there in Korean Diabetic Association annual meeting, representing India and the Diabetes India. It was very busy meeting where more than 2,000 delegates were there. As Korea is very, very active in many scientific meetings. Just before some time, Dr. Makkar was talking that he is currently secretary of our Indian Obesity Society. We are doing Asia-Oceania Obesity meeting at New Delhi, where he is organizing chair. And this meeting have the current president of AOCO is currently from Korea. The purpose of doing this meeting with Diabetes Korea, or rather we are doing multiple such meetings with different organizations around the world. Our collaboration will help our increasing collaboration all over the world. That's the one. And the second, we are also promoting our Diabetes India Congress to all over the world. In this meeting, we have more than 650 delegates registered, but they are not only registered from India, primarily audience which we were expecting from India, but there are many doctors who joined from Korea, many doctors from other parts of Asia too. With this, first of all, I would like to thank my co-chair who is going to discuss and talk about Professor So Hong Kim from South Korea to talk about the Korean Diabetic Association meeting. And then later on, I will introduce our first speaker. This session is primarily on newer technology like diabetes technology for continuous glucose monitoring or update on an incretin-based therapy. These are the two topics. The both topics will be of 15 minutes, followed by a discussion of 10 minutes, what we have planned. So you can send your questions on chat box, which you might be having, because there are two. One is for the faculty platform, and there is a platform for the delegates, so they can write in the chat box. Through audio-visual guide, we will get your question, which we'll be asking directly to the faculty. Our abstract is already those who want to present abstracts in World Congress of Diabetes India. It is already on our platform. You can submit your abstracts. You can also become the fellow of Diabetes India if your qualification and the other qualification for becoming fellow are there. You please apply for your fellowship too. With this, now I request Professor So Hong Kim to introduce Diabetes Korea and to talk about the symposium. Over to Professor Hong Kim.
Okay. Hello, I'm Professor Sohan Kim from Ina University, South Korea. I am currently the chair of the Committee of International Liaison of the Korean Diabetes Association. I'm very pleased to participate as a chair in this meaningful webinar. This webinar is the first to be jointly organized by the KDA and Diabetes India, and it represents an important first step toward closer collaboration and future joint efforts between our two societies. KDA is the main society on research and clinical advancement in Korea. And we are composed of many doctors and nurses, dietitians, and many educators. And now, without further ado, we have the ICDM 2026 in October 15th to 17th in Seoul. So those who are interested can join us. Okay.
Thank you. So with this, now I introduce our first speaker, who is currently organizing secretary also for Diabetes India meeting, which is going to be held at Hyderabad, World Congress of Diabetes and Obesity. Dr. Manoj Chawla is a senior consultant diabetologist based in Mumbai. He is currently director of Lina Diabetes Care Center. He has multiple publications. He is actively involved in many clinical research. He is also published many textbook articles, and he's very active in India as well as globally for giving his talk. And he's also the co-founder of Diabetes Technology. We have created a group of technocrats and some of the persons who are mainly interested in diabetes technology. So we do run a dedicated meeting of diabetes technology, which in this year we have in month of May. Dr. Manoj is doing that is in Mumbai. So now I request Dr. Manoj to talk on continuous glucose monitoring, which he'll be talking in pre-diabetes or for prevention of type 2 diabetes. And then followed by Professor Moon, who will be talking about CGM in type 2 diabetes. So then we will have discussion. So over to Dr. Manoj Chawla.
Thank you. Thank you, dear Dr. Banshi. Let me thank Korean Diabetes Association and Professor Sohon Kim as well as the chair today, along with Dr. Banshi, for inviting me to speak in this session. Let me start sharing the slide and dive directly into the topic. I have the pleasure of speaking alongside Professor Sun Jun Moon, who will be speaking on CGM in type 2 diabetes. So I'm going to take the liberty of doing a little briefing on the CGM itself in my conversation, getting everybody familiar a bit on CGM before we start having the conversation more on the type 1 aspect. I believe my slides are seen and now in the full screen mode as well.
No, it is not in full screen.
Now?
Yes, now it is.
Right. Okay, great. So pre-diabetes and prevention of type 2 diabetes. Well, I have no disclosures, no conflict of interest, except the fact that extremely passionate about prevention and use of technology towards prevention of diabetes. So why is this year pivotal for pre-diabetes action? And I'm glad that you've given me this topic, is because of the numbers. And as we celebrate 75 years of International Diabetes Federation, the fact is there are 635 million adults living with impaired glucose tolerance, so 1 in 8 individuals across the world. The total number of adults with IGT is predicted to rise to 847 million by 2050. You look at those with impaired fasting glucose, 488 million adults from the age of 20 to 79, and this is projected to increase to 648 million. So it's not just the burden of diabetes that we are worried about today, but it's also the burden of pre-diabetes, which seems bothersome. What is continuous glucose monitoring? Going back to the basic, it's a method to track the glucose levels, which actually measures the interstitial fluid glucose levels at a continuous basis, 24 hours a day for a period of anywhere between 10 to 15 days. And also today with the implantable sensors, this works for almost 365 days. There are the demonstration of how basically a sensor works with the transmitter and the sensor tip entering into the interstitial glucose fluid and then measuring the interstitial fluid glucose, which runs in parallel to plasma glucose, though it has a bit of lag period there. Types of CGM, well, essentially you have two types, which is the professional CGM, also called as retrospective or blinded CGM, was of use, at least in the non-reimbursable markets, to look at the trends. Poor availability now in most parts of the world of the blinded professional CGMs, and the predominant use has moved to the real-time CGM, which is used by patients themselves or the physicians empowered and use the connected systems with the patients to see the sugars on almost real-time basis understand the impact of different food and lifestyle choices, and helps them make decisions on medications, especially insulin dosing, and remains connected with the physician's office or even a another health provider in the family to keep a track of your sugars. When you look at the CGM data, to make better understanding of the CGM data, a software was devised called ambulatory glucose profile, which actually is a percentile form of understanding how you can track the CGM data. So it comes as a 14-day graph. You require minimum 5 days of data to form the AGP, but the typical AGP data is of 14 days, though now you can have AGP seen over 30 days, 90 days, and so on. It's a percentile form with this medial line blue giving you the 50% of the data as the median. And then you have the two shaded portions between the 25 and 75 percentiles called as the interquartile range. And then you have the 90% data between the 5th and the 95th percentile called as the interdecile range. The breadth of the AGP graph tells you about the inter-day glycemic variability. More variable in individual, it's going to be broader the graph. Less variable, it's going to be thinner the graph or the snake. The AGP graph is a model day plot. It explains or brings about a good understanding of the glycemic profile over the previous few days, 14 days to be typical, and allows detection of the trends and patterns as well as hidden glycemic issues faced by the patient. Well, when it comes to India, there are different CGM devices which are available. And as I said, I'm not contracted by any particular one for today's conversation, so no conflict of interest. Libre Freestyle Pro was the first time launched anywhere in the world in India, and we did have the privilege of using it the first in the world. Today, it's been largely withdrawn. This is the professional blinded CGM. You do have the Freestyle series of Libre. We had the 1 and more recently the Freestyle Libre 2 Plus, which is easier to use, Bluetooth connectivity, less loss of data, and doesn't require technically flashing or scanning the data, which the Libre 1 series required. Though even with Libre 2, to be honest, there is a chance of losing the Bluetooth connectivity, and the patient is still advised to scan a few times to maintain the continuity of data. Then you have multiple other CGM providers. Sinocare is another one which is used now across the country. The ICANN systems with the ICANN 3 and 6 to be in use. From CGM to CGM1, there are subtle differences which the physician and the patient user need to understand. Then you have Lynx, again, pretty similar to Sinocare. Both are 15 days work on the Bluetooth platform, do not require the NFC phones, and hence less loss of data, and no requirement of having the specialized NFC smartphones with NFC. Your Bluetooth smartphones are good enough to get the data. And all of these are the data transferred to the app on the phone, and which then gets connected to a caregiver in the family or your healthcare professional. You also have another sensor which is now getting used in India, the Tracky one. The difference being that this has a rechargeable transmitter with a warranty of 2 years. Single charge works for 2 weeks. And hence, once you bought the transmitter, the recurrent cost of the sensor is a little lesser than buying the all-in-one unit like the Sinocare Libre or the the Linux series. Now, coming to the question about pre-diabetes, because our topic is prevention of pre-diabetes and using CGM. Well, there are a lot of recommendations, and I'm referring to the latest 2026 standards of care, which says screening for risk of pre-diabetes and type 2 diabetes with an assessment of risk factors or validated risk calculator should be done in asymptomatic adults. Testing should be considered in adults of any age with overweight or obesity and have more than one risk factor. For all other people, you should be screening at the age of 35 and above. But less than 35 with any of those risk factors, which I'll come to, you should still screen them. In people without pre-diabetes or diabetes, after screening, repeat screening at a minimum of 3-year interval. And to screen, fasting or 2 hours plasma glucose, 75 gram OGTT, and A1C are each appropriate. When using an OGTT, ensure that your patient has had at least 150 grams of carbs for the last 3 days. Your risk-based screening for pre-diabetes or type 2 diabetes should be considered at the onset of puberty or after 10 years of age, whichever occurs earlier in children and adolescents who are overweight with a BMI of more than 85th percentile for their age or obese, and who have one or more risk factors for diabetes. Consider screening again where there is use of drugs like statins, thiazides, HIV medications, and so on. And people, those who are on second generation antipsychotic medications, also you may consider screening for pre-diabetes. People with HIV should be screened for diabetes and pre-diabetes and monitor postprandial or random glucose levels with recurrent or long-term use of steroids. This is the criteria for screening in asymptomatic adults. So testing should be considered for anybody with a BMI of more than or equal to 25 or more than 23 in Asians. So for us in Korea and Asia, the cutoff is 23. For those with first degree relatives with diabetes, high risk race and Asians come in that. History of cardiovascular disease, hypertension, HDL less than 35, triglycerides more than 250, individuals with PCOS, those who are physically inactive, people with pre-diabetes should be tested yearly for diabetes. People who are diagnosed with GDM should have testing every 1 to 3 years. For all people living above the age of 35, you should be screening everybody for diabetes and the list as it specifies here. So very clearly, the ADS pointed out. Coming to the use of CGM, well, there are no clear recommendations for the use of CGM in pre-diabetes, but monitoring can never be too wrong. So if somebody has pre-diabetes, there is a huge importance of learning at that stage itself. What the ADA says is use of CGM is recommended at diabetes onset and anytime thereafter for children, adolescents, and adults with diabetes or on insulin or on non-insulin therapies that can hypoglycemia or on any diabetes treatment where CGM helps in management. The specific CGM device and method should be made based on the individual circumstance, preference, and needs. And of course, I would add to that availability and affordability. And people with diabetes on insulin therapy, CGM should be used as close to daily. People with diabetes should have interrupted access to their supplies to minimize uninterrupted access to minimize their gaps in CGM. Strong recommendations were used during pregnancy. And of course, the A1C goals are individualized in pregnancy. In circumstances when consistent use of CGM is not feasible, consider periodic use of personal or professional CGM. Skin reactions should be assessed and addressed. People who wear CGM devices should be educated on potential interfering substances like high-dose vitamin C, aspirin, hemoglobinopathies, and so on. Now, before I move on, there was a very interesting paper which was released at the ATTD Asia Singapore 10 days back, where Dr. Viral Shah, Dr. Tade, Dr. Bergenstahl, and Dr. Philip Moshe released this paper in the Lancet talking about a proposed staging of diabetes. So the question was whether pre-diabetes is the right term because you do not have pre-type 1 diabetes, you do not have pre-hypertension, you have stages of hypertension. So by calling it pre-diabetes, are we doing justice or we should just reclassify diabetes as early and late type 2 diabetes or stages of type 2 diabetes where stage 1 is still normal glycemia. You have stage 2A for slow progressors, stage 2B for the ones which have enough risk factors for progressing fast to diabetes. And within stage 3, you have overt diabetes from stage 3A, which is non-insulin requiring, and stage 3B, which would be more severe form of type 2 diabetes requiring multiple therapies. So a proposed staging in the Lancet, and I propose that whoever's attending this meeting should try and read up the paper. So early intervention with disease-modifying medications. Well, pre-diabetes, what really you define it as impaired glucose regulation with elevated but subdiabetic blood glucose, high risk for type 2 diabetes and cardiovascular disease, multiple different pathophysiologies, early metabolic derangements begin vascular and cellular damage. What do you do for this class of drugs besides lifestyle change? For pre-diabetes, medications that can be considered are metformin, pioglitazone, acarbose, SGLT2s, and the newer anti-obesity medications like semaglutide and tirzepatide once weekly. I must say that US FDA has not approved any of these for use of pre-diabetes. In all associations recommendations, there are these drugs mentioned. In India, metformin is approved by the Indian regulators for the use of pre-diabetes. So let me quickly take you to two cases, which I thought will drive home the point about what we can offer and use of CGM in these patients. This is a 15-year-old female who saw us sometime back in 2023, who was detected with pre-diabetes and hypercholesterolemia, who was started on metformin 3 times a day a week back. Patient wasn't too convinced about taking the drug and then came and saw us. We said, okay, we immediately reduce your metformin to twice a day and we'll see whether you really need it ahead. As I said, it's been an approved drug for pre-diabetes, and there would be many who believe in it and many would not want to start a drug. We suggested that let's do a CGM and look at your profile. And we started seeing that. And we could see that the patient's profile was pretty good, and you're looking at time in tight range. So an important recommendation that when you're looking for patients in pre-diabetes and doing CGM, look at time in tight range, because that's going to help you more than looking at time in range, which is 70 to 140. And you could appreciate that there was 98% of profile was time in tight range for this patient. We started looking at the individual daily profiles. Patient was very well documenting what she ate, which is a great way, again, when you have early diabetes or pre-diabetes, to be able to see what is really spiking it up, and writing it there in the app will share the information with your healthcare providers team. The nutritionists they're seeing that and then guiding you what is pushing it up, what kind of food is responsible for the spikes, and help you control that. We could appreciate a small few drops, though I would say for individuals with pre-diabetes, maybe who are especially not on any medication, or sometimes even on the new weight loss medications, the 60 to 70 on CGM should not be looked upon as worrisome hypoglycemia. It's not genuine hypoglycemia. But having seen her profile and some of the sugar readings on the lower side, we said, let's reduce the metformin ahead. Probably just following the lifestyle modification will be good enough in the long run, and you may not require any drug as long as you're able to bring down the weight and follow the healthier lifestyle. We continue to follow up this patient. She lost weight with her own efforts. She was later on initiated. She wanted to lose weight. As we did not have the injectable semaglutide, patient was started on oral semaglutide, more from assisting her for her weight loss. And she did well, dropped her sugars down to A1 5.8 and lost 4 kgs of weight with her efforts and a little bit of help from oral semaglutide. Oral semaglutide is not a drug which is approved for weight loss or in pre-diabetes. But as we said, this was an off-label use based on discussions with the patient, because we didn't have access in India that time to tirzepatide or injectable semaglutide. Finally, case number 2, again, 52-year-old female, comorbidities, rheumatoid arthritis, hypothyroidism, pre-diabetes, A1C at 5.8, extremely keen to lose weight. The rheumatologist had strongly recommended to lose weight. Patient came to us and to inquire more about tirzepatide. Patient was started on tirzepatide 2.5 milligram once weekly, as we would always do, from the base dose, and then up titrated every 4 weeks to maximum tolerated dose. This is the CGM profile before the patient was started on tirzepatide. Patient had done the CGM and came to us. Again, for pre-diabetes, you can appreciate the TI-TR being looked at between 70 to 140, 83% in range, 17% above the time in tight range. Patient started with tirzepatide. This is few months after starting tirzepatide. We can see the improvement in the profile. Patient is doing a 96% time in tight range. Also, as I said, on drugs like tirzepatide and semaglutide, you may see a little below target. As long as it's level 1 TBR, do not worry, it's not going to be hypoglycemia. So patient did well, lost 8.5 kg over 6 months' time. A1C dropped from 5.9 to 5.1. And this is one of the aspects of treating pre-diabetes besides lifestyle. Somebody who's obese may be given the benefit of the weight loss medications, which are helping in kind of remission from early diabetes to complete normal glycemia. This is the body composition analysis report for the same patient. And I'll draw your attention to the right-sided graph, which shows how the weight went down from 74.7 to 66. What's important that the skeletal muscle mass reduction was minimal and predominantly the body weight percentage loss reduction for this patient. So as I conclude, friends, it's important today that there has to be patient selection for criteria for early intervention, do the risk profiling, see how the response is to lifestyle. If the patient is a candidate for therapy, do a therapeutic match. What do you want to offer this patient? Just lifestyle, metformin, the anti-obesity medications, acarbose has been used and there is evidence for the same and so on. History and genetics are important. Look at the comorbidity and safety. Somebody may have a little bit of heart failure or CKD with pre-diabetes. You may prefer to use an SGLT2 inhibitor for that patient. But whatever you decide in today's times needs to be in conversation with your patient in front of you, which is shared decision making. This was a call to action for clinicians in the Southeast Asian regions on primary prevention of diabetes in people with pre-diabetes, a consensus statement. And our chairperson here, Dr. Banshi Sabu, is a co-author besides many other authors from India and across the globe who came together to have this recommendation for primary prevention of diabetes. So as I conclude, well, let's remember that early intervention with disease-modifying medication may reduce overall diabetes burden. Continued research needed to define long-term safety and benefits and optimal timing. Individualize the care. Prioritize the trials comparing different agents. Diabetologists must take an early lead in this intervention, and multidisciplinary collaboration is the mantra as we move ahead for prevention of pre-diabetes and diabetes. So let me end and leave some food for thought. Data-driven choices prevent diabetes surprises. Prevention is not a cost, it's an investment. Prevent what you can, manage what you must, and which is where I would strongly recommend the use of CGM even in patients with pre-diabetes, because I think that's where the maximum benefit is. When you see it early, the patient is able to avoid and individualize their lifestyle choices, especially on food and exercise. With that, let me stop here and hand it back to the chairpersons.
Thank you. So now I request Professor Kim for introducing Dr. Moon. We will have a question at the end, but fantastic talk, Dr. Manoj. You have covered all aspects of CGM for pre-diabetes and how we can think of preventing. We will have a discussion a little later. It was slightly, we are late. So now I request Professor Kim to introduce Professor Moon.
Okay, now I'll introduce the second speaker, Professor Sunjun Moon. He graduated from Seoul National University in Korea, and he is currently an assistant professor of the Department of Endocrinology and Metabolism of Gangbuk Samsung Hospital, Seongkyungwan University, Korea. His research interests include diabetes technology, CGM, automated insulin delivery systems, and the title of his lecture is CGM in type 2 diabetes. What does the evidence tell us? Please.
Yeah, thank you very much for the kind introduction. And thank you for the great talk for Dr. Manoj. So, good afternoon, ladies and gentlemen in India, and good evening in Korea. So today's topic will be CGM in type 2 diabetes. What does the evidence tell us? Okay, these are today's content. So let me start with introduction. As is well known, CGM collect the glucose data from interstitial fluid, not from the capillary glucose, capillary blood. So they collect the data continuously and show in this graph manner. So now most of you are aware of this time in range concept. So we can now know the time in target range of the CGM value. So now the goal of time in range has been set. So for type 1 and type 2 diabetes, time in target range of 70 to 180 milligram per deciliter is the primary goal, and it should be more than 70%. And for the time below range, it should be less than 4%. But do we really need this CGM? So let us cover some evidence. So as is well known, the hemoglobin A1C, which show the mean value of glucose, being used widely for the standard treatment goal. But why was that? Because it is closely related to chronic complications. But let me say, if someone put their one foot in cold water and the other in the hot water, so the average temperature will be okay, but say this will be comfort. So the same can be applied to glucose. So as shown here, in this left figure, so glucose is very stable within the target of 70 to 180, but with the A1C of 7%. But someone have very hyper and hypoglycemia with the A1C of same as 7%. So yeah, we can say that of course the later one is not good. So there's some evidence of this. So when it comes to variability, many studies reveal that if there is a glycemic variability, it is related to chronic diabetes complications. So we have to correct the variability. But apart from that, hypoglycemia itself has many complications. So as is well known, it caused the confusion and coma, but also impaired memory as well. So it can be resulted in dementia afterwards. So now, not only mean glucose of hemoglobin A1C, but also variability and hypoglycemia should be controlled as well. It is the current concept. For achieving this, CGM can be a very good option. So for the type 1 diabetes, it has this three kind of problem. They have very extreme condition of this problem. So they experience hyperglycemia and hypoglycemia as well extremely. In type 1 diabetes, there have been many studies performed. So many RCTs have been performed. So right now, CGM has been the standard treatment for type 1 diabetes in many countries. So in KDA guideline, of course, for type 1 diabetes, CGM should be offered. And in ADA guideline, CGM should be offered in type 1. And also it should be early in their disease. So we cover for the brief introduction of CGM and type 1 diabetes things. Now we'll move on to type 2 diabetes, and I'll stratify it as MDI treated type 2 and basal treated type 2 and without insulin type 2 diabetes. So firstly, we'll focus on MDI treated type 2 diabetes. So as you know, type 2 diabetes also, their beta cell function will decrease as time goes on. So in the later of their time, they need insulin treatment. Compared to type 1 diabetes, insulin-treated type 2 diabetes showed the similar all-cause mortality and MI prevalence, which is quite different from the non-insulin-treated type 2 diabetes. When it comes to hypoglycemia, also insulin-treated type 2 diabetes showed quite high portion of hypoglycemia, and it is when compared to type 1 diabetes, insulin-treated type 2 diabetes of more than 5 years, the similar hypoglycemia rate was seen. So when it comes to CGM evidence in MDI-treated type 2 diabetes, there has been a landmark study called Diamond Type 2 Diabetes Trial. So it was conducted in the United States with around 160 MDI-treated type 2 diabetes patients. The mean age was 60 and mean A1C was 8.5%, primary outcome as A1C. They used Dexcom G4 or G5, I'm not sure, but Dexcom CGM. So the trial used very simple design. So one group used CGM for continuously for 6 months, and the control group used finger sticks more than 4 times per day. So the adjusted difference was 0.3% of A1C, which was significant. So someone will say that, what's the matter? So only 0.3%. But in this case, for MDI-treated type 2 diabetes, there are not many other options to be applied. So in this case, this is a very significant improvement, we can say. And also the control group used A1C of around more than 4 times per day. So we cannot ignore them. What about intermittent scan CGM evidence in MDI-treated patients? So the landmark trial was REPLACE trial, was conducted in Europe in multinational manner, and the primary outcome was A1C. Unfortunately, actually this study used Libre 1 for intervention group, and control group used finger stick 4 times per day or more. But unfortunately, the A1C was not different between groups. However, only hypoglycemia was reduced in intervention group. So the reason why of this results, we can say that they just provide CGM alone without structured education. So recently in Korea, there has been a randomized control trial called Freedom 2 trial with using Libre 1. So here, the intervention group used Libre 1 with structured education, and the control group 1 used only Libre 1. Control group 2 used finger sticks. So here we can see CGM with structured education group only achieved the A1C improvement compared to control group, not just the control group 1, which used CGM only without education. So now in the guideline in type 2 diabetes, MDI-treated type 2 diabetes in Korea, it is also the highest level of evidence is shown here. And also in ADA, regardless of type of insulin, they recommend to use CGM with the highest level of evidence. Now, moving on with the basal insulin-treated type 2 diabetes. So here, the landmark study has been performed called mobile study. They use also Dexcom CGM, Dexcom G6 in the United States among around 180 basal insulin-treated type 2 diabetes patients. And the control group used more than 3 times per week, the finger sticks. The mean A1C was 9.1%, primary outcome as A1C. So here, they use, the intervention group used CGM continuously for 8 months, and control group used finger sticks, and the A1C difference was shown as 0.4%, and the timing range as 15%. So someone would say again that what's the matter, 0.4%? It is similar to giving just DPP-4 inhibitor, but the thing is here also for the basal insulin-treated type 2 diabetes patients, the next step should be the multiple injection of insulin. So many patients don't want to move to the multiple injection. So just by giving CGM, we can delay the time of time to move to MDI. And the interesting thing is when we discontinue the CGM after 8 months, we can see immediate decreasement of timing range, and also the A1C became worse. So based on this evidence, when the patient with insulin treated type 2 diabetes, the CGM should be used continuously. What about the long-term study of this basal insulin-treated type 2 diabetes? There has been a recent study of Steno2Tech study conducted in Denmark with 76 insulin-treated type 2 diabetes patients, and the basal insulin group was around 80%. Here, for 1 year, we can see the A1C was improved by around more than 15% of time in range, and A1C as 0.9%. For the intermittent scan CGM in basal insulin group, unfortunately there has been no RCT as far as I know, but the retrospective study has been done in this group, and the A1C was improved. For the mixed population of basal insulin and OAD, for intermittent scan CGM, it has been conducted a randomized controlled trial called PDF study in Korea. So OAD and basal insulin group was included. Here, for the 3 months, A1C was reduced by 0.5%. So for the guideline, for the basal insulin treated type 2 diabetes, in Korea, sorry, this is written in Korean, not the highest level, but the second evidence support to use the basal CGM for basal insulin treated type 2 diabetes patients. For ADA guideline, as I said before, regardless of type of insulin therapy, CGM should be offered. Yeah, and last but not least, we'll focus on non-insulin treated type 2 diabetes. So in intermittent scan CGM showed many evidence in this population. So type 2 diabetes without insulin, the immediate trial can be regarded as landmark trial. So they used Libre 1 conducted in Canada among around 116 population. So the timing range was improved by around 9.9% in CGM using group, and A1C also reduced by around 0.3%, which is significant. They used the CGM continuously for 4 months, and the control group used finger sticks. What about the next? Here's also the other intermittent scan CGM study conducted in Japan. They use Libre 1 continuously for 3 months, and the control group used finger sticks. And at 3 months mark, actually the A1C difference was not significant. But the interesting thing is when we discontinue both devices, CGM group showed quite remained effect of A1C, but fingerstick group showed they returned to the original level. So finally, at 6 months mark, A1C difference was shown by 0.3%. So based on this study, maybe non-insulin users, the purpose of using CGM is not insulin dosing, but a lifestyle modification. So this can result in the remained effect of when they discontinue CGM, which is differed by the mobile study, which used the basal insulin. So based on this evidence, my colleagues and I conducted a study, a randomized controlled trial, using CGM as intermittent using manner. So here, the control group used fingerstick only, and the treatment group 1 used 1 week of real-time CGM and then follow up at 6 months mark. And the treatment 2 group used 1 week of CGM and then repeated at 3 months mark for 1 week. So can see the twice using CGM group showed A1C reduction at 6 months mark. So which means in this non-insulin treated type 2 diabetes patients, maybe using CGM as intermittent manner can reduce periodic manner can reduce the A1C compared to SMBG group. But still, we don't know the optimal interval of using CGM in this population. And this is adopted in ADA guideline 2025. Next, we also perform similar study using intermittent scan CGM, and here we use AI camera also. So similarly, we achieved the A1C different only in twice using Libre using group here. So the A1C was differed by around 0.3% at 6 months mark compared to control group. At last, we conducted another study, which is very simple study, design study with the CareSense Air, which is a Korean domestic CGM. So this CGM has the feature of using, we can make it as blinded mode and then change it to unblinded mode within a same sensor. So here, we try to see the pure effect of CGM in non-insulin treated type 2 diabetes because previous study usually performed the giving CGM with structured education. But here we want to see the pure effect of giving CGM alone to the non-insulin treated type 2 diabetes patients. So here we give the CGM in first week with the blinded mode, and then the next day we change to unblinded mode. So here we can see the timing range was the change from 65% to 72% and differed by around 7%. So this is quite great, we think, because without anything, we just giving CGM alone can improve the time range as around 6 to 7%. Lastly, yes, Dr. Manoj covered the many things about prediabetes, but here's the very little single, we can show some evidence of prediabetes here. So in the workplace-based CGM study we conducted among non-insulin treated type 2 diabetes and also prediabetes here. So we provide Freestyle Libre 1 and with the structured education for 2 weeks and then follow at 8 weeks. So here we can see the A1C reduction in diabetes group, but not in pre-diabetes group. But the interesting thing was we can see the weight reduction in pre-diabetes with only giving the CGM here. So now the guideline for type 2 diabetes, non-insulin treated type 2 diabetes. In Korean, the periodic use can be used with the limited evidence, and also for ADA, consider periodic use of personal or professional CGM with the level of evidence C. So in conclusion, in the introduction, we covered the need of CGM and the many evidence in type 1 diabetes. For MDI-treated type 2 diabetes, around 0.4 to 0.5% A1C reduction were seen. And for the basal insulin-treated type 2 diabetes, we also have many evidence. But if we discontinue the CGM, then the glycemic outcome will get worse. So we have to use it continuously. For without insulin type 2 diabetes, CGM, there have been many studies, but right now, periodic use of CGM can be an option for this population. So thank you for your kind attention.
Thank you, Dr. Moon. Now I think we should move over to discussion. Okay. Now, Dr. Sapu.
You can go ahead, Professor Kunal. Banshi's not there. You can go ahead with any questions. Yes.
Okay. How can I receive the questions from the audience? Are there any questions that are here online?
So there are a lot of questions. To start with. I asked Manoj that as such, CGM is not approved even for type 2 diabetes. And we are using for a off level. But do you recommend someone who is even not pre-diabetes? Because there are a lot of people who go to gym for exercise and they do use regularly. Will it give some effect to show that yes, diet is affecting their sugar level? Will it help them to prevent their obesity or weight loss? Is there any role?
So, Banshi, one is, I'm not sure that statement is true, that it's not approved. Even if you see the recommendations from ADA that I showed, for type 2 also, it clearly recommends for patients who are on glucose-lowering therapies, could be sulfonylureas, could be insulin, or anybody else, where monitoring would benefit. So I think it's kind of approved for usage, and monitoring can never be wrong. I'm sure you are the strongest proponent of monitoring. So monitoring can never be wrong. It only comes to where it is reimbursable markets, what is the state ready to sponsor, what is the insurance ready to pay. So monitoring for any individual with diabetes of any kind, or for that matter, pre-diabetes, or for health enthusiasts, as you mentioned, marathoners, runners, health enthusiasts who want to keep a track. Again, I would refer to that paper that you are a co-author for, where you have said that glucose should be the sixth vital parameter to be checked. So glucose continues to be as important as looking at pulse, blood pressure, and other aspects for every individual. So clearly, anybody who wants to keep a track, somebody who has a family history and wants to know earlier what is happening to their glucose, are there any early trends and spikes, it can be a means. I did show in my presentation the proposed staging of diabetes.
हेलो
And for all you know,
हेलो
there may be, hello?
Yes, Makkad,
हाँ
you
अरे
are we can
आप
listen.
चले जाओ वापस घर चले जाओ बेटी को ले
Yes, sorry.
So clearly monitoring will have its benefits. I'm sure that many of us here and in today's forum with the Korean Diabetic Association, we'll come together to work towards more recommendations to rationalize where it should be used, how often is good enough, towards early screening and certain parameters which may come up, like the way time and tight range has come out. There has been some consensus building as to what should be a good time and tight range, and I refer to our conversations at ATTD Asia, where it may be a level of 90 to 95 that may be looked upon as a means of remission for those with pre-diabetes, to look at almost a more than 90% time in tight range to go towards that. So monitoring for anyone, especially in a self-pay market who can afford and understand the importance, should be encouraged to see the trends on the glucose movement.
Right, very rightly answered. I'm sorry that I asked that it is not, approved. My point was that where it is reimbursed market, where it is not. That was the question. Dr. Som, there is a one doctor who is asking, as you might be having more experience of using in Pacific region, many Chinese companies product also, as now it is available. Some of these companies have entered and some of these will be entered soon in our country too. So, and we are also going to have Dexcom and some of the world leaders in monitoring. They will be also available in our country very soon. So their confusion is how, sensitive and specific some of these sensors, which have CE mark, but they are not US FDA approved. So they have, approval from Europe, but not US FDA approved. And how you compare in your countries to some of the products who are US FDA approved against those not approved. Recently, you might have seen IDF Europe also have written one statement on using some of these products in as far as specificity and sensitivity is concerned. And there was a one paper also by ATTD Sideline related to these new products, whether they should be given approval, particularly for type 1 diabetes. We are not worried much about the type 2 because some here or there sugar level will not affect much of them because ultimately they have not to depend. They are looking for more of a trend. But for type 1, where these sugars are very important because they have to take decision immediately for their correction, for their pre-meal boluses also. So where you put all these sensors.
Okay. So maybe okay. So your question was that the many non US FDA approved CGM there has been. So can we rely on that for diabetes and insulin dosing? Is that the right question? That I
Yes.
understand.
Yes.
Okay. Okay. So actually. Yes, there currently many CGM company launched their own CGMs right now. And the thing is and many of them are achieved and have the CE marks, but the thing is, when it comes to using it for AID or very critical case, still we have some concerns of using it. So the to date, the high standard is iCGM for US FDA approval, which needs very qualified standard of accuracy. So as far as I know right now, Dexcom G6 and Libre 2, 3 and Eversense CGM are the only ICGM and Guardian. I'm not sure, but those are the only ICG. They are the only USFD approved CGM with the ICGM. So yes, it is rely on the customers, but we have to think about the accuracy when we use it for very critical use. So can that be answer?
Yes.
But Banshi, can I ask a quick
Yes,
question
please.
to Dr. Moon and Dr. Kim? So you mentioned a lot of other Chinese makers for CGMs. Korea is the source of invention. I wanted to know, are there any Korean makes in CGM that they are using, and anything that we can expect in India in the near future?
I'm not sure, but we have CareSense Air, which is made by iSense company, and it has a CE mark, and as far as I know, they are trying to apply the ICGM approval. But for India, I believe they have the plan for. Of course, India is the biggest market and very good at technology. So I believe they have planned to go there.
That's great. So soon we will have more collaboration even on commercial aspect also. You know, that some Korean company can introduce an Indian market.
Yes.
As we have our meeting of diabetes technology in month of May, we're very happy if some company is really interested. But we have almost more than 10 companies who are marketing their continuous glucose monitoring. We can have few more collaboration. You know, the idea of doing a webinar with two different society, with Korean Diabetic Association and Diabetes India, we can think of some other Indo-Korean projects in terms of writing something on newer continuous glucose monitoring or some newer technology. With this, as we are running late, short of time, so I am thanking both the speakers, Professor Dr. Moon and Dr. Manoj. Will be meeting again, and I will request, if possible, for both of you to stay back for the next session. Professor Kim, should I introduce Professor Dr. Makkar?
Yes, please.
So, Dr. Makkar is a senior consultant, diabetologist, and bariatric physician. He is the one who started long back a obesity clinic, and before 25 years, rather, I will say, when nobody was thinking that primarily obesity management will become a key area for managing diabetes. Professor Makkar is currently holding many positions, but he is very active in obesity and Indian Obesity Society. He is currently Secretary of Indian Obesity Society. For this Diabetes India meeting, World Congress, he is organizing chair of the meeting. So I will request Dr. Makkar to talk on his topic for 15 minutes. Later on, we will request Professor Lee to talk, and then we'll have question answer at the end. Dr. Makkar, over to you.
Thank you, Dr. Banshi, for very kind introduction. I think I am audible.
Yes, you are audible and listen.
Okay. And I am really honored to be on this platform, and I am very much pleased that we have, collaboration between Korean Diabetes Association and Diabetes India to have joint webinar, where I am honored to be part of. We are already working with the, Asia Oceania Group in obesity, and we are hosting the AOCO conference, which you see in my backdrop from tomorrow onwards in New Delhi, India. And some of our Korean friends are already here for the meeting. So it's a great pleasure to be here. Let me share my presentation. Can you see my presentation now?
Yes, we can see you.
Okay, great. So, as you know, my presentation is going to be on dual incretin agonist from glycemia to metabolic health, and I will try to finish in 15 minutes time. I don't have any financial disclosures for this presentation. The concept of dual incretin started with the first presentation which I listened to at the ADA meeting in 2011, which was the Outstanding Scientific Research Award by Professor Matthias Schops, where he showed that there are multiple complex neurohormonal mechanisms which are involved in the causation of or regulation of food intake, the body weight, as well as body glucose, blood glucose, and they are all interconnected. And therefore, it is unlikely that we can have a cure based on a single hormone. He also suggested that that was the time to abandon the concept of cure based on single hormones, and we need to look at combination therapies for both diabetes and obesity, focusing on the gut hormones and adipokines. That time he came up with the concept that if we can combine two hormones into one molecule to produce two receptor recognition with single molecule. And this was the concept of coagulation. And the first molecule that was formed was a combination of GIP, GLP-1 and GIP. And dosing with this pegylated mixed agonist in diet-induced obese mice resulted in 26% weight loss and 42% of the adipose fat tissue mass. And the interesting thing was this weight loss was much more significant as compared to the single GLP-1 receptor agonist. Not only that, the molecule produced better weight loss than liraglutide, and it was sustainable in mice over a longer period use. And this led to the development of molecule tirzepatide. Now, basically, this molecule or mixed agonists have dual receptor recognition capabilities. These are smart molecules where one molecule can, recognize two different receptors. For example, if we look at GIP and GLP-1, they will stick to their own receptors. GLP-1 will identify GLP-1 receptor, and glucagon receptor will identify the glucagon receptor only. But once you have a combination, the same molecule is, recognizing two different receptors. And this smart receptor recognition has led to the whole change and development of GIP, GLP-1 dual agonists. We know tirzepatide now is already in the market. It is a multifunction peptide based on the native GIP-1 GIP peptide sequence, modified to bind both GIP and GLP-1 receptors. It has a half-life of 5 days and can be given as once a weekly dose. And this has activity against two pharmacological targets. And by this two target, activity, there is synergy. Suppose we are using GLP-1, there is increased satiety, but there is increased nausea also, while the GIP receptor agonism cuts down nausea. On the other hand, GIP agonism also leads to increased lipolysis, increased insulin sensitivity, and also decrease in the ectopic fat accumulation. So you can induce synergy by using two receptor recognition in one molecule or targeting two receptors to achieve the targets. Now, first molecule, as I mentioned, was tirzepatide, which was developed, and the initial studies with tirzepatide showed that in people with diabetes, not only we were able to achieve a weight reduction of going up to more than 2%, there was also significant reduction in weight going up to around 10 to 12%. This led to development of the SURPASS study program, which was the tirzepatide development program. And it clearly showed that when tirzepatide was given to people with diabetes, type 2 diabetes, as a monotherapy or as add-on to metformin, led to significant reduction in weight, which was going in the range of 10 to 12%. There was significant reduction in A1C going more than 2 to 2.5%. And if you look at the starting A1C, it was only 7.5, 7.9 to 8.3%. So that means we were having significant number of people achieving targets below 7% and 6%. And if you look at the numbers achieving target of less than 5.7%, which is like normalization of the glucose levels, happened between 26 to almost 60% of patients treated with tirzepatide. Not only that, because of the weight reduction, tirzepatide was further studied for management of obesity, and this was the SURMOUNT program where tirzepatide was studied in multiple studies in people with obesity without diabetes, except for SURMOUNT 2, which was in people with obesity and type 2 diabetes. Now, I will largely focus on patients in SURMOUNT 1 and SURMOUNT 4 trial, which included more than 3,000 patients. And the Surmount 1 was published way back in 2022, clearly showed that over a 1 year period of usage, even with the 5 milligram dose, which is the lower dose, there was 16% weight reduction. And at the higher dose of 15 milligram, there was almost 23% weight reduction. Not only that, the number of people achieving more than 10% weight loss were almost 90%, more than 15% were more than 75%, and more than 20% were almost 60%. So there was significant number of people achieving significant weight loss, 9 out of 10 achieving more than 5% weight loss only at 5 milligram dose, 3 out of 4 achieving more than 10% weight loss with 5 milligram dose. And if you look at the higher dose, 8 out of 10 achieved more than 15% weight loss, and 2 out of 3 achieved more than 20% weight loss. Now, if you look at the waist circumference, that is the central adiposity reduction, there was 20 centimeter reduction in the waist circumference. Not only that, there was improvement in the cardiovascular risk factors. There was almost 8 to 10 millimeter reduction in systolic blood pressure, 5 millimeter in diastolic blood pressure, reduction in triglycerides, improvement in HDL, and reduction in LDL also. In addition, if you look at the adverse reactions, they were similar to GLP-1 therapies. Now we have follow-up data of SURMOUNT 1, 3 years follow-up, and the 3 years follow-up data clearly shows that a significant number of people who achieved the higher weight loss were able to sustain weight loss over 3 years period. Now, we also had tirzepatide studied in people for MASLD or MASH in phase 2 trial, which was published the last year. This was phase 2 study which looked at efficacy and safety of tirzepatide in patients with MASH and moderate to severe fibrosis. And tirzepatide for 52 weeks was associated with greater effect than placebo in terms of resolution of MASH and without worsening of fibrosis. So there is indication that this drug may be useful in people with MASLD also. Not only that, we had the presentation of cardiovascular outcome study on tirzepatide, which was surpassed CVOT at the last ADM ESD meeting in Vienna in September this year. The study, focused on efficacy of tirzepatide compared to dulaglutide on first occurrence of the 3-point MACE, which is the primary outcome. And the primary objective was to initially determine non-inferiority of tirzepatide compared to dulaglutide, which was the active comparator in this study. The secondary endpoints, included the extended MACE. So there was additional coronary revascularization, time to occurrence of CV death, all-cause death, and cardiovascular death. So this study included people more than 40 years of age with type 2 diabetes and established ASCVD with the A1C in range of 7 to 10% and body mass index of more than 25. They were all initiated on 2.5 milligrams with 4 weekly up titration going up to 15 milligram or the maximum tolerated dose, and the comparator was dulaglutide. Though this was on 1.5 milligram weekly dose, but there was sham dose escalation which happened in this arm also in the blinded manner. The study involved 640 sites across 30 countries and finished enrollment in 2022. Both the groups, the tirzepatide and dulaglutide, were nicely matched. The average age was 64 years, 30% were women. The Asian population was about 9%. If you look at the ongoing therapies, there was similar, matching in both the groups. If you look at the history of atherosclerotic cardiovascular disease, almost 65% had coronary artery disease, more than 50% had revascularization, and half of them had myocardial infarction also. Now, if you look at the change in A1C and weight, there was significant reduction in A1C in the tirzepatide arm as compared to dulaglutide arm, and there was significantly better weight reduction as compared to dulaglutide arm. And if you look at the primary endpoint, there was reduction in the 3-point MACE, but it did not achieve statistical superiority. So it was non-inferior to dulaglutide in terms of 3-point MACE reduction. However, if you look at the secondary endpoints, the extended MACE was statistically significant in terms of superiority over dulaglutide, and the all-cause mortality was also significantly lower in the tirzepatide group. This is the all-cause mortality with hazard ratio of 0.84, and this was statistically significant. And if you look at the safety profile, most of the patients reported side effects similar to the GLP-1 RA therapy. This is the comparison if we consider, the population that was on dulaglutide, which has been shown to be superior to standard of care in people with diabetes. So if we compare the results of tirzepatide against a putative placebo, not against dulaglutide population, then you will see all the results achieve more or less, all of them achieve statistical superiority. So to sum up, treatment with tirzepatide met pre-specified criteria of non-inferiority and met criteria of superiority when compared with the putative placebo. It did not meet superiority for comparison of tirzepatide and dulaglutide for primary endpoint. Overall, SURPASS-CVOT demonstrated that tirzepatide is cardioprotective in participants with established ASCVD and type 2 diabetes. Now, we have some evolving therapies in pipeline, which are again using the GLP-1 molecule as the backbone, and you have combinations in pipeline like GLP-1 GIP, GLP-1 glucagon, GLP-1 PYY, and so on. And these are interesting number of molecules in pipeline. We have data from survodutide in phase 2 trials, which is a GLP-1 glucagon receptor agonist, and has shown not only significant reduction in body weight, but also improvement in MASH in almost 85% of the participants without worsening of fibrosis. And this is being further studied in synchronized studies and leverage program. We have a molecule in development in China, and this is the GLORY-1 trial, which showed again that mazdutide was much better than placebo in terms of reducing weight, achieved almost 15% weight reduction. Then we have very interesting molecule called maridebart cafraglutide or maridide, which is a long-acting peptide antibody conjugate. So this combines the GLP-1 receptor agonism with GIP receptor antagonism and is developed for treatment of obesity. So this molecule consists of two identical GLP-1 peptide analogs conjugated with single monoclonal antibody antagonist against GIP-1 receptor with half-life of 21 days, so it can be easily given once a month. And the data from this studies has clearly shown that gives you a statistics, very significant weight loss going to 20%. In people with diabetes, again, there is significant weight loss. There was A1C reduction only 0.4% in non-diabetes population, but in people with diabetes and obesity, there was more than 2% A1C reduction. So we have interesting molecules in pipeline in terms of dual agonist or agonist antagonistic combinations also, which we'll see in near future. With that, I conclude my presentation. I think I finished well in time, and I am going to stop sharing my screen.
That's great. Thank you, Dr. Makkar. Now I request Professor Kim to introduce our next speaker, and then we will have question at the end. Yes.
I'll introduce the second speaker, Professor Young-Hoo Lee. He is currently professor in the Department of Endocrinology and Metabolism at Yonsei University College of Medicine. He is an active and renowned clinician and researcher in the field of diabetes, MASH, obesity, and aging. He is also a key member of the KDA and is currently the Director of General Affairs of the Korean Diabetes Association. The title of his lecture is Triple Co-Agonist, How They Will Reshape Treatment Strategies in the Future. Please, Professor Lee.
Thank you, Chairperson, for a nice introduction. And I will share my, can you see my slides? Can you see my slides?
Yes.
Okay. It's a great honor for me to have this opportunity to present my presentation in this meaningful symposium. And I really thank Dr. Sabu and Gupta for organizing the first Diabetes India and KDA joint symposium. In Korea, our association biannually publish the diabetes fact sheet in Korea, and I'm going to show you the current status of obesity in diabetes people in Korea. Like approximately half of people with diabetes are obese, and especially when you look at the left circle indicating that more than 13% of people with diabetes, they have class 2 or 3, which indicates severe obesity. And as you're all aware, like higher BMI is associated with poorer glycemic controls, as you can see when we target lower than HbA1c 7%. And also it is associated with increased risk of diabetic complications and also healthcare cost in people with diabetes and obesity. And also, when we look at the MASLD or metabolic dysfunction associated steatotic liver disease, as you can see, if people with diabetes and fatty liver disease, they have higher increased risk of steatohepatitis or MASH with advanced fibrosis. And especially compared to the people with no diabetes, they have really higher prevalence of MASLD in Korea, like twofold higher prevalence of fatty liver in people with diabetes. And also, according to our recent paper, we analyzed the impact of MASLD and diabetes and significant fibrosis on the mortality from the Korean National Health Examination Surveys. As you can see from the red box showing here, if people have diabetes, they have 1.3-fold increase of mortality. But if people have diabetes and fatty liver disease, their mortality has synergistically increased up to like 1.9-fold. And also, if people with diabetes, fatty liver with significant fibrosis, they have almost 2.3-fold increase in the mortality, which indicates that we also have to manage diabetes, but also fatty liver disease. So the concept, like previously, Professor Maka nicely represented about the impact of GLP-1 and GIP on the metabolic organs, including pancreas and fat and brain. You all know this kind of dual agonism is really good for modulating the metabolic health in people. But nowadays, many researchers and clinical trials are focusing on the agonism of glucagon because that can increase the energy expenditure, and also it can delay gastric emptying in the stomach, and also it has good effects on the liver fat metabolism. So briefly mention about the known actions of glucagon. Usually glucagon receptors are predominantly found in the liver, but some tissues such as pancreas, kidney, and intestine and adipose tissues or brain, certain of brain part of brains, they express glucagon receptors. And many researches have been conducted about the functions of glucagon in our whole body metabolism. And usually it can increase the energy expenditure, and also it can modulate the gastric emptying motilities. So briefly summarize the potential mechanism of action of glucagon in metabolic diseases. As I mentioned, one of the most powerful function of glucagon, it can enhance the energy expenditure during the weight loss, because if people get weight loss, then mechanistically their energy expenditure will go down because of the compensatory mechanism. But if we induce glucagon levels in those people with weight loss, that can enhance the energy expenditure. And also glucagon can reduce the food intake, and appetite regulation also occurs. And also regarding the lipid metabolism, you all know that glucagon can burn the fat and regulate the cholesterol metabolism as well. And also certain research regarding the role of glucagon in inflammation also published, like it can modulate the inflammation, especially in the asthma or other chronic diseases. So currently, many pharmaceutical companies are making the glucagon as a therapeutic target, as the Professor Maka nicely mentioned about the impact of mazutide on clinical trials, but also other survodutide made by Boehringer Ingelheim also doing the phase 3 trial focusing on obesity and MASH. And also other company like Korean company Hanmi, they're also making a triple agonist like a retatrutide, and also other companies are making even like triple and quadruple agonist right now. So briefly mention about the survodutide is a glucagon GLP-1 dual agonist, and last year it published a clinical phase 2 trial on MASH. And as you can see, this kind of drug is a agonist ratio of glucagon and GLP-1 receptor like 1 to 8, so which means the very mild agonism for glucagon, but strong agonism for GLP-1 receptors. And you can see after treatment over 48 weeks of survodutide, you can see a nice resolution of MASH with no worsening of fibrosis up to more than 50% compared to the placebo. But unfortunately, because this is a phase 2 clinical trial, so the reduction of fibrosis was not significantly improved. Because our team is doing a MASH cohort, MASH multi-omic studies. So from our MASH cohort human liver samples, we conducted bioinformatic analysis from the human MASH samples. And you can see from the normal to simple steatosis, MASH, and MASH fibrosis, you can see when we analyze the RNA data focusing on the glucagon signaling in the liver, you can see when the liver histology is impaired, then it can decrease the glucagon signaling. And also, when we analyze the single cell data from the public data set, you can see certain hepatocytes are decreased with glucagon receptors in the liver when they have MASH or MASH with fibrosis. And you can see the dark blue color means the decreased expression of glucagon-related signaling, which indicates that because people with MASH, they have glucagon signaling is decreased, so maybe glucagon agonism might be good for the treatment of MASH. Also, according to the tirzepatide clinical trials, like similar to the semaglutide, with the treatment of dual agonists, it can decrease the glucagon levels in the human people. So that indicates also if we additionally increase the glucagon activity with the triple agonism, then it can enhance the energy expenditure because tirzepatide can decrease the glucagon signaling as well. So, as you all know, dual agonism is very good for like insulin secretion, insulin sensitivity, and regulating the appetite and delaying the gastric emptying. But when we additionally increase the activity of glucagon with the triple agonism, as you can see shown in the green color, it can beneficially increase the insulin secretions, and also it can enhance the energy expenditure with the appetite regulation, and very good for the liver in terms of the fat metabolism. And also, glucagon can also delay the gastric emptying pathways. So to briefly introduce the triple agonist, retatrutide is a novel synthetic molecule which can increase the activity of GIP, GLP-1, and glucagon receptors. And as you can see, the very potent, like 9-fold greater potency to the native GIP compared to the retatrutide. And also, it can a little bit decrease, like 3-fold less potency than the human nature glucagon compared to the retatrutide. And also, regarding the GLP-1 activity, it's also the potency is less. So this is like GIP more focused molecule, but that can also mildly increase the activity of GLP-1 and glucagon. So from the mouse model published in Cell Metabolism, as you can see, compared to the tirzepatide, retatrutide with the same concentration, it can promote greater body weight loss than the dual agonism, which can be a very powerful drug for the weight reduction. And also, I'm going to introduce the phase 2 clinical trial data published in Lancet and NEJM, focusing on the diabetes in the front and the obesity without diabetes. So this is the clinical trial phase 2 design for the patients with type 2 diabetes. They used placebo and dulaglutide compared to the retatrutide from the 0.5 milligram to 12 milligrams, and they treated for 36 weeks. And they are all type 2 diabetes and BMI over 25. So when you look at the impact of retatrutide on HbA1c, you can see HbA1c dropped up to like 2.16 percentage from the baseline with the highest dose and the retatrutide 8 milligrams. As you can see, compared to the lower dose of retatrutide, it has nicely decreased in the dose-dependent manner, but I think the ceiling effect is similar to the 8 milligrams and 12 milligrams. When you look at the proportion of participants achieving A1C lower than 7% or 6.5%, their proportion is very similar compared to the 8 milligrams and 12 milligrams. And also, this kind of thing is, I think, less potent than the dual agonism because the glucagon also can slightly increase the gluconeogenesis. So I think A1C lower than 2.1 is like a little bit lesser than the tirzepatide. However, when you look at the body weight reduction by the triple agonism, you have really potent drug for the weight reduction. With the retatrutide 8 milligrams and 12 milligrams, it decreased up to like more than 16 kilograms from the baseline, and very nice dose band manner. And when you look at the proportion of participants achieving weight reduction more than 5% and 10%, you can see like 5% and 90% of people have achieved. And for the more than 10% of weight reduction, also more than 70% of people. And also when you look at the 15% of weight reduction, it's more than 55%, which is a really powerful drug for weight reduction. However, when you look at the safety profiling, when we combine the proportion of people who had nausea, vomiting, or diarrhea, you can see the green indicates the mild symptom and yellow indicates the moderate symptom. And you can see the, oh, sorry. So from the higher dose of retatrutide from the 8 and 12 milligrams, you can see quite a higher instance of these GI adverse events. And I think because of the glucagon also can delay the gastric emptying, so that can be a slightly problem for the dose adjustment. Next, I'm going to briefly touch upon the retatrutide phase 2 clinical trial for the obesity. And you can see there is a retatrutide 1 milligram to 12 milligrams compared to the placebo, and they treated for 48 weeks without people with diabetes. And also from those clinical trial, there is a sub-study focusing on the liver fat contents assessed by the MRI PDFF. So when you look at the body weight reduction over the time period, you can see because these are the people without diabetes, so their weight reduction was up to 24% at the higher dose of retatrutide 12 milligrams. But when you look at the 8 milligrams, very similar, like 23.9% as well, because their body weight baseline was the 107 kilograms. So they have really like almost the like 20%, more than 20% of weight reduction. And also when you look at the proportion of participants achieving the weight reduction, you can see very potent weight reducing effects. Like when you look at the proportion more than 15%, you can see from the retatrutide 8 to 12 milligrams that achieve more than 70% people. Also, when you look at the biomarker improvement, focusing on the insulin sensitivity, HOMA-IR, fasting insulin dramatically went down, and also good hormones such as adiponectin went up, and also leptin went down. When you focus on the liver fat, this is a sub-study with people with 98 people, and you can see relative liver fat reduction was achieved more than 80% of reduction, which is really potent for the liver fat improvement. And also the down graph indicating the PRO-C3 levels. This is a surrogate biomarker for the liver fibrosis because they did not do the liver biopsy, but when you look at these surrogate markers of liver fibrosis, it achieves a lot. So nowadays, ongoing phase 3 trials with retatrutide are conducted as shown here, like transcendent type 2 diabetes are ongoing, and also people with obesity and type 2 diabetes, there is a program called Triumph, and also phase 2B trial focusing on the renal function as well. And also there is a synergy outcomes study focusing on the muscle and liver-related outcome clinical trials. This is like they are recruiting 4,500 participants with MASLD, and they included based on the non-invasive biomarkers such as LEF or liver fibroscans, which indicates the people with MASLD and advanced fibrosis, they are enrolled. And one arm is the tirzepatide group, and one arm is the retatrutide group. And they're looking for the primary endpoint as like malo or major adverse liver outcomes, such as cirrhosis development or other liver-related events occurs. So we have to wait and see whether this kind of outcome trial has impact on the livers. So to conclude, glucagon is a pleiotropic hormone that regulates glucose, liver, and amino acid metabolism, and also it can modulate the appetite and energy expenditure. So dual and triple agonism with GLP-1 and GIP and glucagon also shows the synergistic benefits on the liver metabolic diseases such as obesity, type 2 diabetes, and fatty liver disease. And current phase 2 clinical trials of liraglutide with obesity and type 2 diabetes shown promising results for the weight loss and improved glycemic control, and also it significantly reduced liver fat up to 85% of people. So I'd like to close with the advertisement of Korean Diabetes Scientific Meeting, which will be held in October 15th in 2026 in Seoul, Korea, COEX Mago. Because this year, thanks to Dr. Sabu and other Indian doctors, among 32 countries who attended ICDM this year, participants from the India, they were 51, and surprisingly 151 abstracts submitted from the India, and 42 Indian researchers got travel grants supported by KDA, and this is the website. And I'd like to close with Tsuneke Danyabad.
Thank you.
Brilliant.
Very good, Dr. Lee. I mean, fantastic talk. And ICDM is really very, very popular in our country. You can see that how many abstracts were there and many Indian scientists and researchers were there. And we are thanking Korean Diabetic Association that they have given travel grant to more than 41 young researchers who could travel for ICDM. I was there, as I told in my talk also, that it was really a wonderful meeting where thousands of doctors were there. So there are a few questions, Dr. Makkar and Dr. Lee. We have with us Dr. Amit Gupta. Welcome. Dr. Amit is currently Joint Secretary of Diabetes India. Dr. Makkar, there is one very important, there are a lot of new GLP and GIP analogs are there. So what's their purpose of coming with a different, newer combination? As weight loss is already a primary target, which we are almost achieving with dual or a one of the molecule, which is triple. Are they looking for primarily a muscle preservation? Because that's a major challenge when they are losing the weight. Is it that, or are they looking for more cardio protection or the other organs protection, whether it's a liver or kidney or a person's with diabetes or obesity? It's for other things. So what's the purpose of, I mean, still that's research is going on. And some of the molecules which are coming like amylin and the other analogs, and again, still dual and triple agonist in a different combination. So where will be the future? It will be for clinician will be very confusing that where to use this dual or this triple. What's the situation? What you are thinking?
So, Dr. Bansi, very good question. And I think it is not just confusing, it is very exciting also. You know, till the time we had only liraglutide, we were all the time struggling with weight. Though we were able to, get down the A1Cs better than the other molecules, still we were struggling with weight. And of course, cardiovascular, benefit is one of the things that we came to know from the leader trial. Now, if we look at, the type 2 diabetes population, almost 80% of people with type 2 diabetes are either overweight or obese. And we know now that adiposity contributes significantly to development of not only insulin resistance, but also development of, atherosclerotic cardiovascular risk also. The whole process of atherosclerosis is, enhanced by adiposity. It leads to increase in the adipocytokines in circulation, leads to endothelial dysfunction, it leads to hypertension, leads to, now we know EPAT is one of the factors which is directly impacting heart. We know it has direct impact on kidney. So obesity is possibly mother of all diseases. And this needs to be, tackled in people with type 2 diabetes. And we have enough data to show, especially after the bariatric surgery initial data and then the direct trial, that if we are able to induce significant weight reduction early in the course of disease, we can lead to remission of diabetes, which is very, very important. So I think we were looking for molecules which can give us better weight reduction, and then we came up with semaglutide, which has the potential to cut down the appetite more than 2 times the liraglutide was doing. And because of this significant appetite reduction, there was significant weight reduction both by central mechanism and both by reducing the
ત્યારે
appetite.
ચાલવાનું થાય એ વખતે થાય છે પછી પોતાય તો ઓછું
And
થઈ જાય
Dr. Manoj,
Yeah.
you have to, yes.
So, weight reduction is a very important component, but we hardly had any molecules for weight reduction. And second thing is the pathways we were exploring earlier was largely the serotonin pathway. And whatever we used for weight reduction on serotonin pathway or the cannabinoid receptors, we ended up on wrong foot. And we ended up banning of all the drugs, whether we started with dextromethorphan or sibutramine or rimonabant or even lorcaserin recently. All drugs got banned. It is the only GLP-1 pathway which has appeared to be safe, cardioprotective, and beneficial in terms of target organ damage. And that is why the whole story of using multiple agonism started. And the first talk I briefly mentioned in my presentation, the history when Matthias Schopp gave the concept that we have to look at all these processes, whether it is the weight reduction or it is the the glucose metabolism or the fat metabolism. All these are interconnected through multiple neurohormonal pathways, and they need to be addressed simultaneously, and we need multiple receptor, interventions. And this is how the whole story is developing. And now we are seeing, look at the data from Surpass. You are achieving weight reduction of 22%. You are getting A1C reduction of 2% or more, starting from A1C of 8%. So you are practically putting everybody in the euglycemic range. Look at the tirzepatide data. Everybody, more than 90% people are achieving weight loss of more than 5%. Earlier, we were targeting only 5 to 10%. Now we can target 25% weight reduction with these molecules, which are in pipeline. And you are seeing beneficial effects. Now, glucagon pathway has the advantage of being used synergistically because it has some effects which are different than GLP-1 and both create synergy. Like I mentioned briefly that both will reduce appetite, but GLP-1 increases nausea, GIP will reduce nausea. GLP will increase lipolysis and fat mobilization, especially from ectopic sites, which makes it beneficial for the ectopic fat deposits. So I think this is just the beginning. We are still learning. We are going to learn more and more pathways, and we are going to learn more benefits. Now, as for the muscle preservation is concerned, both GIP and GLP do not lead to any kind of muscle preservation. There we are looking at, some part of it may be the amylin receptor agonism, but we are looking at molecules which are different. We are having bimagrumab, which is a monoclonal antibody, active receptor blocker, which has been shown to preserve muscle mass and increase muscle mass. We have protein kinase, phosphokinase activators in pipeline, which have been shown to increase muscle mass at the same time reducing weight. We have some, now tetra agonists and quintuple agonists which are coming in pipeline. There is a combination which was presented at the ADA meeting, which has GIP, GLP-1, glucagon, and IGF-1.
So we will just have a short question. I
So,
agree with that.
so many things are happening.
Thank you. So now, Dr. Lee, where will you see the future of plain GLP-1? Like we have the data of semaglutide, but in compared to that, the data of dual agonist, which is GLP, GIP, like tirzepatide, where you will see that a person who have a choice of using either of these molecules, even we have the data for both the molecules for CV also, but the benefit of weight loss is found to be more with the tirzepatide. So where you will find the future of plain GLP-1 instead of GLP, GIP in combination, like tirzepatide, which is available, and in future, there are many more such molecules that are going to be there. Dr. Lee.
Yes, thank you for the important question. As you know, because GLP-1 based and dual agonism has really good data for the obesity and type diabetes and muscle D as well. So I think we have to focus on how can we select people who can more benefit from these kind of drugs. I think because one of example nowadays many society suffers from the increased prevalence of young onset diabetes, like who are aged 20 to 30 when they're diagnosed with diabetes. Those people with young onset, they have really higher BMIs with really hard to control glycemic burdens. So I think that kind of drug can also very good for the people with young onset diabetes who have higher obesity and other comorbidities. But the problem is the issue of the price, because young people with diabetes, they don't have enough like economic status. So I have to, we should more focus from the Diabetes Society. We have to think how can we apply this kind of good drugs for these people who needs but who cannot like afford. And also the problem is, although that can decrease body weight a lot, but as you know, like there are also muscle loss, which can induce like sarcopenia. And also when you stop this kind of good drugs, that can induce weight regain, which can mostly occur by the increased fat mass with like already decreased muscle mass. So, but we cannot use forever for this kind of drugs. So I think many pharmaceutical companies are both focusing on muscle preservation with weight reduction by like Professor Maka nicely mentioned about the bimagrumab, but other companies also are using other receptors such as like GLP-2 or activin type 2 receptors. Then maybe we can expect in the future for focusing more muscle mass and fat as well.
Great.
Yeah.
There is one more question from Dr. S.K. Mohanty, and he's asking whether GIP will be more effective in liver or in brain. So if we are talking of GLP and GIP combination, as we have the data of using GIP along with GLP, but do we have data only of using GIP? Will it be more effective at liver fat or at brain liver? If we have any data which is published, or do you know, please comment on it. Any one of you, Dr. Makkar or Dr. Lee?
See, to best of my understanding, to begin with, the GIP was kind of considered, a non-functional component in body. Initially, we didn't understand GLP also has some important function, and we all thought that GLP was the molecule working. Now we know that GIP also can have actions going through GLP-1 receptor and also directly through GIP. So by we have molecules both in development with GLP-1 agonism as
if you have any study where only GIP single molecule is being studied and found to be more effective either to reduce liver fat or at level of brain to decrease either appetite or to increase or decrease weight gain both. So do you have any data? Because as far as I know, so it is always studied along with GLP.
yes.
Initially, when they thought that as it is one of the inert molecule, but then later on they realized if we use in combination, probably it is also very effective to reduce weight as well as to reduce sugar. But do we have any data where only GIP alone, maybe in phase 1 or phase 2 study, is any data is there? Do you know?
Not to best of my hand.
Yes,
Yeah,
Doctor.
I can show you some my slides. Yeah, as you mentioned, like there is a like investigational drug focusing on the agonism of GIP. You can see my slide.
Yes.
Yeah, like green bar indicates the GIP receptor agonist, focusing on the weight reduction and glucose control. As you can see, compared to the DULA and GIP, like there is a mild weight reduction up to like 3 kilograms, and also A1C lowered 0.7 by the GIP receptor agonism. And also, when you look at these data, like insulin secretion are mildly increased, and also insulin sensitivity is improved a lot compared to the GLP-1, which indicates the like GIP receptor agonism is more focusing on the improvement of insulin resistance.
So mecupetide is one of the GIP receptor agonists, which has been single also is studied for. Thank you.
Yes.
Thank you very much. We have more than 750 doctors who have participated in this webinar from different parts of the Asia, and around 500 doctors are from India who joined. We would like to give them a certificate of attendance also, so we'll request Korean Diabetic Association Authority, please send and share your signature also. So we would like to give the certificate of participation to all our participants from the side. With this, now I request Dr. Amit Gupta for proposing the vote of thanks to Korean Diabetic Association, as well as to all our participants and the speakers. Over to Amit, and then we can close the session.
Thank you, Dr. Bansi.
Thank you.
And yes, Dr. Manoj, you wanted to say something?
No, I just wanted to thank everyone and go ahead, Amit. Just wonderful to have everyone on this forum.
Yes. Thank you, everyone. And I'm sure all the 700 participants, they must have learned a lot. And the questions, they were really very insightful. And the Korean faculty and the Indian faculty, Dr. Manoj Chawla, Dr. Brij Makkad, Dr. Lee, Dr. Soo Kim, and Dr. our dear friend Sanjun Moon as well. We recently met him in Singapore as well. So we are very grateful to you for kind association with Diabetes India. And we look forward to continuously strengthen this partnership. And we look forward to many of you to come to Diabetes India meeting and host you in month of February. And all the participants who are listening, just few other reminders that abstract submission is still open for the Diabetes India meeting. The fellowship applications are open, and the last date for the submission of the application is 31st of December and 2025. So I hope many of you will be applying for the Fellowship of Diabetes India. And very soon we will be releasing the scientific program. So we look forward to host you, all of you, at Diabetes India meeting. And another 2-3 webinars are coming up in this series, which we are doing with our international partners. So very, very grateful to you for this association. Thank you very much.
So Professor Lee, you can share our Diabetes India brochure. And I'm sure the way, 141 abstracts were there from India in Korean Diabetic Association meeting. We expect similar number of abstracts if they can come from Korean Diabetic Association meeting also. With this, thank you once again. And it may be good night for Korea, but still, evening, and we have a lot of patients here in evening time, most of us. So thank you very much. Thank you for your
So we can, instead of saying bye, we can close with a Korean heart.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.